Howdy, y'all. Now let's go over dystonia. Dystonia is classified according to etiology as idiopathic or symptomatic. Primary dystonia is where dystonia, which is sustained muscle contraction causing twisting and repetitive movements or abnormal postures, is the sole major symptom. Therefore, no etiology can be identified. Primary dystonias are further subdivided by criteria such as age of onset, distribution of affected body parts, presence of diurnal variation of symptoms, responsiveness to drugs, and genetic markers. Secondary dystonia refers to dystonia in the context of neurological disease in which dystonia is the only one of several symptoms or in which dystonia is a result of an environmental insult. Causes of secondary dystonia are some of the following: neurodegeneration, as seen in Huntington's disease, juvenile Parkinson's disease, Wilson's disease, lysosomal storage disorders, and Rett syndrome. Dystonia plus syndromes involve double responsive dystonia, myoclonus dystonia, rapid onset dystonia, Parkinsonism. The following list is long, but bear with me. It's important for secondary dystonias. According to exogenous causes such as medications like dopamine agonists, acquired exogenous causes such as medications like dopamine agonists, dopamine receptor blockers, anti-epileptic agents, levodopa, calcium channel blockers, toxins such as manganese, carbon monoxide, carbon disulfide, methanol, warfarin, perinatal cerebral injury such as cerebral palsy, kernicterus, vascular lesions such as stroke, arteriovenous malformation, antiphospholipid syndrome, infections such as encephalitis, subacute sclerosing encephalitis, HIV/AIDS, abscess, brain tumors, paraneoplastic syndromes, demyelination such as multiple sclerosis, pontine myelitis, trauma such as head trauma, cervical cord injury, structurally in cases of atlantoaxial subluxation, Klippel-Field syndrome, and Arnold-Chiari malformation, Parkinson's disease, and other Parkinsonism diseases such as progressive supranuclear palsy, corticobasal degeneration, multiple system atrophy, other movement disorders like disorders familial proximal kinesiogenic dyskinesias, familial proximal non-kinesiogenic dyskinesia, and episodic ataxia syndromes are all causes of secondary dystonia. Generalized dystonia tends to have its onset in early childhood. DYT1 dystonia is the most common cause of early onset generalized dystonia, usually starting in the limb. It is associated with three base pairs, guanine, adenine, guanine, GAG deletion, and axon 5 of DYT1. However, there is a large phenotypic variability even with families with an identical mutation. Primary generalized torsion dystonia is a progression disabling disorder that usually begins in childhood and is located to several loci. In many cases are inherited as autosomal dominant traits caused by deletion in the tosin A gene, DYT1 locus, resulting in the deletion of glutamine tosin A, a brain protein of unknown function with highest concentration in the substantia nigra. Dystonia is often misdiagnosed due to its rarity and unfamiliarity. Features as psychogenic disorder, penetrance of 30 to 40%, and clinically expresses as generalized dystonia to occasional adult onset focal dystonias, beginning as a focal action dystonia before the middle third of life, with most cases beginning in childhood. Approximately 65% of cases progress to generalized or multifocal distribution, 10% become segmental, and 25% remain focal. Childhood onset cases evolve to a generalized dystonia which produces severe disability owing to serious gait and posture abnormalities. This can result in serious life-threatening conditions, status dystonicus. Most primary dystonias have normal routine neuroimaging studies, 18E fluorodeoxygenase and positron emission tomography. Has been used with a novel regional glucose metabolism in primary torsion dystonia. This pattern is not specific for DYT1 genotype. It can be present in other primary dystonia genotypes, and the network imaging is not routinely available. Diagnosis of dystonia. First consideration is whether dystonia is secondary, particularly one that has an effective treatment, including discontinuation of other treatments. Some clues to secondary dystonia are history of trauma or exposure to drugs, infection, cerebral anoxia, etc. Dystonia arrests rather than with action and its onset. A typical site for age of onset, for example, leg onset in an adult, cranial onset in a child, early onset of speech abnormality, hemidystonic, presence of abnormalities other than dystonia on neurological exam or general medicine exam. Non-physiologic findings suggestive, psychogenic basis, abnormal brain imaging, abnormal lab tests. Treatment of dystonias have been primary pharmacological and symptomatic, including levodopa blockers of central muscarinic cholinergic receptors, benzodiazepines, and valprofen. Anatomically targeted administration of agents is also used as a botulinum toxin and intrathecal administration of baclofen. The most effective treatment of generalized dystonia is a high-frequency stimulation of the globus pallidus, pars interna, through the surgical placement of a deep brain stimulator. 3 questions for you guys out there. Now, I know I kind of rushed through this again, but bear with me. I'm trying to help y'all and help myself. Got to get through them bows, but I got to help y'all too. So let's get on with the 3 questions. A 32-year-old man with repetitive painful muscle spasms and abnormal movements is diagnosed with DYT1 dystonia on basis of clinical presentation and ruling out secondary causes. Drugs most likely to help this patient symptoms are: is it haloperidol, trihexyphenidyl, brand name Artane, phenytoin, or chlorpromazine? Oh man, you good. It's trihexyphenidyl Artane. It's correct. It is an anti-muscarinic, anticholinergic. In severe cases of DYT1 and other primary generalized dystonias, what should be used? Anticholinergics, benzodiazepines, valprofen, or DBS of the globus pallidi. DBS is deep brain stimulation. Oh man, that's a good answer right there. You good? It's DBS of the globus pallidi, deep brain stimulation. Now let's go on to the last question. This question's an easy one, but a hard one. What differentiates dystonia DYT1 from a psychogenic disorder? It's a contraction of the left leg, contraction of the right arm, or loss of sensation above the neck. You good. You got that sensory part, huh? You got that part down? Alright, yeah, it's a loss of sensation above the neck. That will make it a psychogenic disorder, not a dystonia DYT1. Alright, until next time, howdy folks. Like to see y'all later. Bon voyage, and y'all man. About to go shoot me some deer.